dispatched to 47 hospitals as interventional radiologist. He completed his MBBS from Shade GS Medical College and KEM Hospital in 2012, his MD from Lokmanya Tilak Municipal Medical College and General Hospital in 2015, in which he also stood first. He completed his DNB from Lokmanya Tilak Medical College and General Hospital in 2016. Then he did his fellowship in endovascular neurointerventions from Shanghai Hospital, Shanghai, China. He has a teaching experience of 3 years as assistant professor in Lokmanya Tilak Medical College and Hospital. He holds skills in therapeutic and diagnostic interventions in neurointerventions, peripheral interventions, as well as ultrasound and CT guided procedures of the head and neck and spine, and also in microwave ablation of tumors. He has several publications at national and international levels to his name. So to begin with, we'll first understand the anatomy of the thyroid gland, for which I would like to call Dr. Nehal, Associate Professor, ENT Department at SC Hospital, to deliver the talk.
So, good morning everyone. Myself, Dr. Nehal Patel, Associate Professor in Sataban General Hospital. So, here I am presenting to you anatomy of thyroid gland. So, let's begin. First, we go with embryology of thyroid gland. It is the first endocrine gland to develop at about 24 days of gestational life. Thyroid gland develop from the first and the second branchial arches from the proliferation of the endodermal epithelial cells on the floor of the primitive pharynx between the tubercle impera and the cupula. Subsequently, it descends in front of the pharyngeal gut as a bilobe diverticulum, and which is connected to the tongue by narrow canal, which is known as a thyroglossal duct. By week of the 7th gestational life, it reaches anterior to the trachea and having acquired small median lobe with 2 lateral lobes. Subsequently, thyroglossal duct usually disappeared. So it fully functional at the 7th week of intrauterine life. Now we see size and shape of the thyroid gland. It is the largest endocrine gland, which is butterfly in shape. Each lobes measure about 5 by 2.5 by 2.5 centimeter in size, and isthmus about 1.2 by 1.2 centimeter in size. Its average weight is about 15 to 25 grams. It is larger in female compared to in male, and it is increase in size during pregnancy and menstruation. It is responsible for regulating body's metabolic rate via hormone it produces. Now we go with structures. It has 2 lobes, 2 lateral lobes which are pyramidal in shape with its apex directed upward and base downwards, with median isthmus connecting to lateral lobes. There is 1 small pyramidal lobe also present. It's seen in 30 to 40% of the population. It is conical in shape and extends from the upper part of the isthmus and reach up to the thyroid cartilage to the hyoid bone. Now, location of the gland. It is situated in the anterior part of the neck, lying against and around the larynx and the trachea, reaching posteriorly up to the esophagus and the carotid sheath. It starts cranially at the oblique line on the thyroid cartilage and extends inferiorly to approximate 5th to 6th tracheal ring. So, on the vertebral level, it extends from the C5 to T1 vertebral level. Now, capsules of the thyroid gland. Thyroid gland has 2 capsules. 1 true fibrous capsules which enclosing the gland, and false fascial capsules which is derived from the pretracheal layer of the deep cervical fascia. It is thin along the posterior border of the lobe but thickened on the inner surface of the gland to form a suspensory ligament of Barry's on each side, which is connected to the cricoid cartilage. So, thyroid gland or any other thyroid swelling which moves with the deglutition or swallowing, because thyroid is attached to the cricoid cartilage of the larynx by the suspensory ligament of Barry's. Now, relation of the gland. First we see relation of the isthmus, and later we see relation of the lobes. So, relation of isthmus. Isthmus has 2 surfaces and 2 borders. 2 surfaces, there is anterior surface and posterior surface, and 2 border, upper and lower. So, anterior surface is formed by skin, superficial fascia, anterior jugular vein, deep fascia, and sternohyoid and sternothyroid muscles, while posterior surface is formed by tracheal ring, which is second, third, and fourth tracheal ring. Its upper boundary is made up of right and left superior thyroid artery. Sometimes there is pyramidal lobe also present, which are directed upward from the isthmus. And lower border is formed by the right and left inferior thyroid vein, and sometimes thyroid ema artery also present at the lower border. Now, relation of the lateral lobes. Lateral lobe has three surfaces: posterior, medial, and anterolateral. So its posterior surface is formed by two parathyroid glands, superior and inferior, embedded in the posterior surface, two arteries, which is common carotid artery inside the carotid sheath, and the inferior thyroid artery before entering into the gland. Now, medial surface is formed, upper part of medial surface is related to the larynx. In larynx, it is related with thyroid and cricoid cartilage with cricothyroid membrane and inferior constrictor muscle with external laryngeal nerve also. And lower part of the medial surface is formed by trachea, esophagus, and the recurrent laryngeal nerve. Now, anterolateral surface is formed by skin, superficial fascia, and deep fascia. Its upper part is crossed by the superior belly of omohyoid muscle. Middle part is covered by the sternohyoid and sternothyroid muscle, and the lower part is formed by the anterior border of the sternocleidomastoid muscle. Now, arterial supply of the thyroid gland. It is supplied by the superior thyroid artery, which is branched from the external carotid artery, inferior thyroid artery, which is branched from the thyrocervical trunk, and sometimes there is thyroid artery also present, which is the branch from the arch of aorta. Now, venous drainage mainly drained via superior thyroid vein, middle thyroid vein, and inferior thyroid vein. Now, lymphatic drainage of the gland. It is mainly drained by the prelaryngeal lymph node, also known as a Delphian node, which is in front of the cricothyroid membrane. There are pretracheal lymph nodes also, paratracheal lymph nodes, and the upper and the lower deep cervical lymph nodes. Now we go with nerve supply of the thyroid gland. It is supplied by the external laryngeal nerve, which is arise from the superior laryngeal nerve at the level of the greater cornu of the hyoid bone, which descends posterior to the superior thyroid artery and pierces the inferior constrictor muscle at the level of the thyroid tubercle to enter into the cricothyroid membrane. So, it is cricothyroid muscle is the only muscle which is supplied by the external laryngeal nerve. Other nerve is the recurrent laryngeal nerve. It is branched from the vagus nerve that supplies all intrinsic muscle of the larynx except cricothyroid muscle. There are two recurrent laryngeal nerves, one on the right and the left. The right and the left have a not symmetrical course. Right have a shorter course while left has a longer course. Left nerve looping around under the arch of aorta and right nerve looping under the right subclavian artery, which travels upward. Both travel alongside of the trachea and enters into the tracheoesophageal groove. Now there are some important triangles during thyroid surgery for known of the different vital structures during the thyroid surgery which we face difficulties. So one is the Beher's triangle, also known as the Riddle's triangle. So it is bounded by, base is formed by the common carotid artery, superiorly it is the inferior thyroid artery, and third side is formed by the recurrent laryngeal nerve. It is important for the identification of the recurrent laryngeal nerve. One important triangle also is the Joule's triangles, which is mainly used for the identification of the superior laryngeal nerve. It is formed by the superior border is formed by the superior attachment of the strap muscles, medial border by the midline, and the lateral border formed by the upper pole of thyroid gland and the superior thyroid vessel. Triangle of concern, it is the commonest site of bleeding during the thyroidectomy surgery. It is made up of trachea medially, recurrent laryngeal nerve laterally, with thyrothymic ligament and loose fat above, and the sternum at its base. And last triangle is Simon's triangle. It is also important for the identification of the recurrent laryngeal nerve, which is formed by the common carotid artery laterally, esophagus medially, and the inferior thyroid artery superiorly. Thank you.
Thank you very much, madam, for simplifying the anatomy such explicitly. Next, I invite the radiology department to help us understand the thyroid anatomy under ultrasonography, and I'll invite Dr. Nidhi for it.
Hello everyone, I'm Dr. Nidhi Patel and today I'm presenting the USG anatomy of thyroid gland under the guidance of Dr. Viplav Gandhi sir. Any patient that presented with the midline swelling or thyroid swelling, the first investigation we do is the ultrasonography, because superficial location of thyroid gland and the high resolution grayscale and the color Doppler sonography can demonstrate the normal thyroid anatomy and the pathological conditions with remarkable clarity. Also, the ultrasound is less expensive, simple to do, and the higher resolution. By palpatory method, we can palpate up to the 1 centimeter of the nodule, but by USG, we can see up to 1 millimeter of the nodule. USG has a high sensitivity for nodule, but poor specificity for the malignancy. The instrument we use in the USG is a linear high frequency probe, which provides the adequate penetration and the high resolution images. Newer techniques are also available, that is contrast enhanced sonography and the elastography. How we perform the ultrasound of the thyroid gland? First, we explain the patient about the procedure. After that, we tell patient to lie down in the supine position with its neck is the extension. Sometimes we put a pillow under the shoulder in the fatty patient and who has a short neck for the better visualization of the thyroid gland. And for the lower pole visualization, we tell patient to swallow so that it can prominent the lower pole of the thyroid gland so we can see it clearly. After thyroid gland screening, we also look for the neck screening or neck lymph nodes. Basic anatomy, as we discussed, thyroid is the anterior-inferior part, located in the anterior-inferior part of the neck in the infrahyoid compartment, 2 lobes connected by the narrow isthmus. As we can see in the anatomical figures, relation of the thyroid gland, here we see the anteriorly the strap muscles. Just anteroinferiorly, there is the sternocleidomastoid muscle. Center part is the trachea. Posterior to is the esophagus, and these thyroid glands are surrounding the trachea. Exactly the same image in the transverse section we seen in the USG, in which we can see the right lobe, left lobe of thyroid, and the isthmus. Central is the trachea. Laterally, just strap muscle, and just laterally to that, there is a sternocleidomastoid muscle. Posterolaterally, there is a carotid triangle, which you can see is common carotid artery and the internal jugular vein. Here, the esophagus we mainly seen in just posterior to left lobe of thyroid. In the USG, we see for the thyroid volume and Doppler images and the parenchyma. First, thyroid volume. In the thyroid volume, we measure by 2 methods, the linear parameter and the mathematical formula. In the linear parameter, we measure the AP diameter, which is relatively independent of the possible dimensional asymmetry between the 2 lobes. AP diameter greater than 2 centimeter consider the enlarged. In the other mathematical formula are the in longitudinal view and the transverse view, we measure the width, depth, and the length of the thyroid. Here is the USG images of that. And by that, we measure the thyroid volume. Normal thyroid volume in adults is of 10 to 11 plus or minus 3 cc. Second, we look for the thyroid parenchyma. As you see in this picture, normal thyroid gland has a homogeneous appearance with the medium echogenicity. Sometimes the capsule appears as a thin hyperechoic line. Blood supply, as we discussed, the arterial supply is from superior and inferior thyroid artery, which is derived from the external carotid and the thyrocervical trunk, and the venous drainage by superior, middle, and inferior thyroid vein that drain into the internal jugular vein and innominate vein. The third thing we see in the USG is a color and power Doppler ultrasound. because it's useful to evaluate the vascularity of thyroid gland and the focal masses. Thyroid gland is a highly vascular structure, and the thyroid arteries can be visualized on the color Doppler examination, while the flow parameter, just like PSV from this vessel, can be measured by the spectral Doppler examination. Here we see the ultrasonography of inferior thyroid artery, Doppler examination. This seen in left lobe of thyroid, just lateral to its common carotid artery, and just posterior to left lobe of thyroid we see is the inferior thyroid artery. So superior thyroid artery and vein generally found at the upper pole of each lobe, and the inferior thyroid vein and the artery is located just lower third of lower pole. And we measure the peak systolic velocity by Doppler examination. Normally the peak systolic velocity is 20 to 40, which is highest in the superficial organs, and PS sometime in the disease like thyrotoxicosis, Graves disease, we found PSV greater than 100 centimeter per second. After normal USG, we see about the thyroids. If any nodule found in the USG examination, we see for these 5 parameters: composition, echogenicity, shape, margin, and the echogenic foci. According to that, we measure its points, and we divide it into the thyroids 1 to 5, in which thyroid 4 to 5 is moderately and highly suspicious for the malignancy, and type 1 and 2 are the benign. First we see for the composition. The first black looking anechoic structure, well defined, that is the cystic lesion, and second is a sponge-like lesion, well defined, in which we give it a spongiform lesion. The third thing, we found both cystic as well as the solid component. We call it as a solid cystic lesion, and the fourth is a solid lesion, in which we cystic lesion and the spongiform lesion are gave the 0 point. Solid cystic lesion gives the 1 point, and the solid lesion we gives the 2 point. After that, we see for the echogenicity of each nodule. First, we will see the echogenicity is mainly compared with the normal thyroid parenchyma. If first picture we see the anechoic cystic-like echogenicity. The second picture we see the lesion is a hypoechoic compared to the normal thyroid gland. So we call it as a hyperechoic lesion. And in the third picture we see the echogenicity same as the thyroid gland. So we call it as an isoechoic lesion. In the fourth picture, the thyroid is a hypo compared to the surrounding thyroid parenchyma. So it is a hypoechoic lesion, and the fourth is a very hypoechoic lesion. Third thing is a shape. If thyroid nodule is wider than the taller, as seen in the fourth picture, we give it as a 0 point, and if taller than the wider, we give it as a 3 point. Margins. In the first picture we see is the well-defined margin and the smooth margin, and the second picture we see is the irregular or lobulated margin, we give it as a 2 point, and the third picture we say the extrathyroid extension, we give it as a 3 point. After that we see for the echogenic foci. If not, there we give the 0 point. If cometal artifact as given in this picture, first picture, cystic lesion with cometal artifact, we give it as also the 0 point. And in this picture, we saw the calcific foci which casting the posterior acoustic shadow. We label it as a macrocalcification. In next picture, we see the peripherally hyper line, that is peripheral rim of calcification. And the third picture, we see the punctate echogenic foci. Punctate echogenic foci is more suspicious for the malignancy. In the summary, we call that cystic lesion, which is mostly anechoic, wider than the taller, smooth or regular margin, sometimes thin halo, which is a vascular, and no calcification or sometimes cometal artifact. That mainly we call it as a benign looking lesion, and the suspicious lesion are mostly solid cystic or completely solid, hypoechoic or very hypoechoic, taller than the wider, lobulated or irregular, extrathyroid extension, and macro calcification, X-ray calcification, or the micro calcification, and internodular vascularity mainly consists of an suspicious for the malignancy. Here is 3 example. In the first example, we see the very well defined mixed solid cystic lesion which has a echogenicity is same as an surrounding normal thyroid gland. Shape is very tall, wider than the taller, so we gave it as a 0 point, and margin is smooth, so we gave it a 0 point. No any echogenic foci are found, so we gave it as a 2 point, that is Thyroid 2 region. In the center, we see the solid looking well defined lesion with echogenicity is same compared to the surrounding thyroid, and no echogenic foci are very tiny echogenic foci are found, so we gave it as a 3 point. This is a Thyroid 4 lesion. On the third picture, we see the solid looking hypoechoic, very hypoechoic lesion which has a very regular smooth margin or very regular shape and lobulated margin, and echogenic foci in the second picture macro calcification, and the first is a micro calcification is there. So we gave it as a 8 point, and it is a Thyroid 5 lesion. The other modality like elastography is add on the information for benign and the malignant lesion, which is based on the principle that when body tissue are compressed, softer part deform more easily than the harder part. The amount of a displacement at various depth is determined by the ultrasound signal reflected by the tissue before and after they are compressed, and the corresponding strain are calculated from this displacement and displayed visually. Contrast enhanced sonography is also useful, but it is not very widely used. Which is second generation contrast agent we are using, and very low mechanical index can provide useful information for diagnosis of selected cases of the nodular disease and for ultrasound guided therapeutic procedure. Thank you.
Thank you very much. Now I would like to felicitate few faculties here. I call upon Dr. Ila Upadhyay, Head of Department ENT at BJMC. Please felicitate her with a flower bouquet. Thank you, madam. Next, I call upon Dr. Viplav Gandhi, sir, who is the head of the Radiology Department at SCL Hospital, and also thank them for the kind support in organizing this event. Thank you very much, sir. I'd like to invite Dr. Atul Kansara, sir, who was professor and head, ex-professor and head, LG Hospital, Ahmedabad. Thank you very much, sir. I would like to invite Dr. Nipa Dalal, madam, who is the head of ENT department at NHL Medical College. I would like to invite Dr. Vatsal Patel, sir, who was the professor of ENT department at SCL Hospital. I also invite Dr. Saket Rao, sir, who we have here, who is an interventional radiologist at Zydus Hospital, Ahmedabad. We welcome you, sir. Okay. We also welcome Dr. Rosal Gandhi, sir, who's also an interventional radiologist in Ahmedabad. Okay. So we'll now proceed to the surgery department you'll have been waiting for. We have 5 cases with us, and I'll give a brief intro of these cases. PPT. So this is a patient who is a 19-year-old female who presented with anterior midline neck swelling since 3 months. She was euthyroid and she had a lesion of approximately 11 by 17 by 88.5 millimeter in the right lobe of the thyroid. Her left lobe of thyroid and isthmus were normal in size, and she had a Bethesda 2 category 2 colloid cyst.
You can start. Am I audible there? So good morning everybody. I am Dr. Monal Bhuta. I am an interventional radiologist. So today we have come here for basic live cases for microwave ablation of thyroid nodules. So before we start, we'll just have a brief ultrasound anatomy review of the thyroid gland. First we are starting with the normal thyroid lobe. So this is the left lobe, which is the normal thyroid lobe. This is the thyroid lobe. This is the carotid artery, and next to it is the internal jugular vein. A simple way to differentiate the carotid from the IJV, just to give gentle compression, and you will see that the jugular vein gets compressed, whereas the carotid pulsations are still visible. Now, before we start going ahead with the procedure, it's always better to have a brief overview of the normal thyroid anatomy. So that once you are aware about the normal thyroid anatomy, then you will be able to identify the abnormality. Now, like I said, this is the left lobe of thyroid gland. If you go posteriorly, this part, this is what we call the danger area, or mainly here we can see the esophagus the esophagus. Now, when you come to the midline, if you freeze at this structure, can you just freeze it for me? Yeah, perfect. This is a central view. This is the tracheal shadow, which is shown on the tracheal rings. This is the left lobe of the thyroid. This is the right lobe of the thyroid. And this part is the isthmus, what we are seeing here. You freeze? बंद हो गया? Hello, hello. Is it audible? Can somebody speak from there and inform whether it is audible? Hello, hello.
Hello. Conference room.
Yeah, am I audible? ત્યાં એમને કહો ને કે માઇક લઈને બોલે એમને સંભળાય છે એટલે આપણને અહીંયા સંભળાઈ જશે. ઈ ત્યાં બોલશે માઇક પર ને કે એમને સંભળાય છે કે નહીં તો આપણને અહીંયા સંભળાઈ જશે. હેલો.
Hello.
Done? Can we start? Sure, no? So again, I don't know how much was missed there, so again I'll show, please. See, this is what you call the central view of the thyroid gland. This is the left lobe of the thyroid gland. This is the right lobe of the thyroid gland. This is the tracheal shadow, which is seen because of the tracheal cartilages. And the part here, this is the connecting part, what we call the isthmus. Now we'll move to the abnormal side, that is the right lobe of the thyroid. And once we screen, this is the nodule. Freeze. This is the nodule which is seen. Now this basically is a mixed ecogene, what we call a solid cystic nodule. Now when we talk about microwaves, now when we talk about basic microwave ablation, the basic principle is that you are introducing a microwave antenna, and that antenna is going to deliver microwave energy in the form of heat and is going to ablate your nodule. I always say that microwave ablation is not like a replacement of your thyroidectomy or a hemithyroidectomy, but it's like an additional tool which is available to offer to the patient. Now the basic principle of microwave, how it works is that it generates when the microwave energy is delivered, it generates a rapid rotation of the protons at a very high speed, which leads to the heat formation, and that heat formation leads to what we call ablation of the nodule. Now, the ideal temperature of microwave usually ranges between around 80 to 90 or up to 100 degrees. Usually above 100 degrees, it's not advisable, because above 100 degrees, there's the process which happens, something what we call as charring. So there is a difference between coagulative necrosis and charring. Our aim is to cause coagulative necrosis, so that once you cause coagulative necrosis, the macrophages and the body cells are going to eat up that eventual necrotic component, and which is going to lead to size reduction. Now, whereas if we cross a certain temperature, like more than 100 degrees, it leads to charring of tissue, which is also called carbonization. Now, if we cause charring or carbonization, the macrophages are not able to digest those tissue, and the nodule may get ablated, but you may not get a significant volume reduction. Now, coming to the basic anatomy on the left side, is that the basic principle of microwave is that you're going to deliver heat energy. So the thing which you're worried about is to prevent any collateral damage happening because of the heat energy which is going to be delivered. So if you see the screen here, this is the nodule. Yeah? Everyone can appreciate the nodule there. This is the nodule. Yeah, freeze the screen. Now, if we see this section, what are the important areas which are to be protected is that this is your carotid artery, and the carotid artery is bang close to your thyroid nodule. Here is your tracheal groove, the thyrotracheal groove, and posteriorly is what we call the danger area, where usually the recurrent laryngeal nerve is located. So now the whole principle is going to be that you need to create a barrier between your vital structures and the nodule, so that the heat energy which is getting dissipated does not reach those critical areas and is restricted only to the nodule. So what is the ideal criteria we say is that there should be a distance of at least 3 millimeters between your nodule and your vital structure. So for example, if when we are going to do a dissection, we want a fluid layer of at least 3 millimeters separating the nodule and the vital structures, so that we can safely ablate without causing any collateral damage. Betadine? Yeah. Okay, so now what we'll do, now we'll start with the first step. Now the first step is basically just to give local anesthesia in the superficial plane, so that henceforth when you introduce your antenna and your hydrodissection, the procedure becomes relatively painless for the patient. So we're taking 10 ml of lignocaine. Release कर दो यहाँ दिया. Now show the hand. Sorry. Can everyone appreciate the needle on the screen?
Yes, we can appreciate.
Yeah.
So what is the dose and how much you inject?
Yeah, so right now I have taken 10 ml of lignocaine without adrenaline, and we're going to inject it in the superficial plane.
Dilution of lignocaine?
No dilution, pure 10 ml lignocaine. Okay. Now, before we go ahead with the next step, I would just like to tell you there are basic different approaches which are there for thyroid nodule ablation. Now, one that is which is called as a trans-isthmic approach, that is also called as a medial lateral approach, and second one is called a lateral to middle approach. So if you see the screen here, yeah, can you please freeze the screen? Perfect. Now see, if everyone can see here, this is the thyroid nodule. So this is the middle aspect where you can see the tracheal shadow, and this is the lateral aspect. So there are two approaches which we can.
What is the size of the nodule and FNSA report?
They'll tell. I think it's around 18 to 20 mm. Bethy is that. And Bethy is a type 2. Yeah, perfect. So I was describing there are two approaches. This is what we call a transisthmic or a medial to lateral approach, and this is what we call as a lateral to middle approach. Now the choice of approach usually depends on the location of the nodule. The basic principle of your choice is that you want to take your antenna, that your microwave probe, as much as away as possible from the critical area or the danger area which you are going towards. So in this case, a preferable approach will be to go from transisthmic from middle to lateral. Now before we ablate, like I said, the most important step of this procedure is to do what we call hydrodissection. Now like I said, the whole principle of hydrodissection is to create a fluid barrier around the nodule so that you protect your critical structures. Now coming to the solution, there are different options which we can use for hydrodissection. You can use cold saline, you can use cold D5. You can also use a colloid solution. The advantage of colloid solution is that the absorption rate is slower. So sometimes once we do the hydrodissection, if you're taking a little more time to get your access or to get proper section, by the time you start the ablation, the fluid may have reduced in size. So it's also advisable to use a colloid which will give you a longer duration of your hydrodissection staying here. Right now here we are going to use cold D5. Yeah. So before we start the hydrodissection, mentally we need to prepare one thing. We need to analyze which are the structures here which we are going to protect. So looking at this image, there are three things which we will have to protect. Number one is going to be a carotid artery. Number two is going to be your tracheal rings, and the number three is going to be your posterior area. Okay. First, we'll start with dissecting the thyroid capsule and the muscle layer from the thyroid gland. थोड़ा सुई लगेगा. Yeah, everyone can see the needle?
Yes.
Yeah, saw that? So now there is a fluid barrier created between the thyroid and the strap muscles. Next. Yeah. Now next hydrodissection is going to be between the trachea and the thyroid nodule. Okay.
Which gauge needle you are using?
A 21 gauge needle.
Oh.
See, now luckily we got a good plane, so even the danger area has got nicely separated. ऊपर देखिए आप, ऊपर देखिए. Yeah. Okay. The last thing which we're going to separate is, so that fluid has tracked here also along the thyroid, along the carotid also. If you see, there's a good fluid barrier. So now all directions, if you see medially, your निगलिए मत सर. Here also there's a fluid barrier. The posteriorly also you can see the hydrodissection which has traversed, and even laterally the carotid is also well protected.
Dr. Maunil?
Yeah.
Have you gone through the isthmus to dissect between trachea and the nodule?
Sorry, your voice is not very audible. Loud, volume बढ़ाइए ना mic का.
Hello? Have you gone through the isthmus to dissect between the trachea and the nodule?
Have you? Sorry, sir. Have you? Yes, we gone through the isthmus. Correct. Yes.
Okay.
उधर का ना mic का volume बढ़ा दो so that we can hear the questions. Yeah. So now the hydrodissection part, if you see, hold it. Freeze the screen once I tell you. Wait. Yeah, freeze the screen. Yeah. Now see, now everyone can appreciate the nodule. This was the nodule, right? Now this is the trachea which is separated. This is posteriorly the danger area which is separated. This is the carotid. So all 360 degrees surrounding the nodule, now there is a good fluid barrier. So now we can safely advance the microwave antenna. Yeah. Give me the antenna. So before we advance, I'll just briefly show you how the microwave antenna works. No, no, you can't touch that. Yeah. Perfect. Happy doing, man. So see, this is the basic microwave antenna system. Now, what are the different components? First, this is the actual microwave antenna. Okay, I'll describe what antenna is this. This is the cable cord, and this is the tubings which are required for the cooling of the antenna. Now, if you see this antenna, it has got these two ports. These are what we call for the cooling. Now, just focus on this antenna. Now, this entire antenna, if you see, the actual ablation is going to happen only from this white point. Can everyone see this white point here? Now, this is what we call a cooling tip antenna. So, the entire shaft is continuously going to be kept cooled by the cold saline which is going to be rotating through this tubing. It is only the tip which is going to emit your heat energy and going to lead to the ablation. Now, why it has been made this way? Because in many patients, when there were uncooled tip antennas were being used, this entire thing, the shaft used to get heated and eventually used to cause skin burns. So, to prevent that, it is only the white part which is going to emit the heat and which is going to lead to the ablation. Now, how does it work? Where is the, yeah. So, this is the cable cord which attaches here. You have to switch on the machine.
What is the gauge of
Get
this
the machine
electrode?
closer. Sorry?
A gauge of the electrode? 18 gauge? or
16 gauge.
16 gauge.
So, microwave, there are two antennas which are gauges which are available, 16 gauge and 17 gauge. Yeah. Okay. Now, while they are setting up the machine, now when it comes to ablation of the nodule, there are usually two techniques which are used for ablation. One is what we call a single shot technique, and second is what we call as a moving shot technique. Now, what is the basic difference is that in single shot technique, you place your antenna in a particular place and you deliver a prefixed amount of energy. Now, the antenna is kept stable in that place, and after giving a particular setting, it will ablate a particular sphere or a particular diameter and volume of the tissue. However, in that, so that technique is actually more suited when you do a microwave ablation of like a liver tumor or a liver mets or a lung tumor. When it comes to thyroid ablation, it is safer to do something what we call as a moving shot technique. What is moving shot technique is that you are continuously pulling your antenna back, and that antenna at each point is ablating a small sphere. So it's like, imagine you have to ablate one big sphere. So rather than ablating the entire sphere in one shot, you are piecemeal wise, you are ablating small spheres, and you are ablating the entire nodule. The advantage of moving shot is that you are reducing the risk of collateral damage, and you're reducing the risk of surrounding structures getting damaged. 30 watts. Now, coming to the settings, the usual recommended settings for microwave ablation is between 30 to 40 watts. However, if the patient is thin, if the nodule is small, then it is safer and advisable to do it at 30 watts. Yeah? Betadine? That you have to give them. Just be careful, antenna shouldn't fall. Yeah. See, now what has happened, as because we have discussed with time now, the fluid around the tracheal tube has reduced. So once, before we actually start the ablation, we will just put some more fluid and separate it better again. So this was the reason I was saying that a colloid gives you a better, more duration, because the absorption rate of colloid by the body is slower as compared to D5 and saline. Give me one more needle. Yeah. So we'll just do the dissection a little bit more again.
Can you point where the danger triangle is?
Sorry, just do something on the mic volume, please.
Can you point the danger triangle?
No, I can't hear. Get the speaker inside. If just 1 second, the voice is not clear here. તમે આવી જાઓ અંદર. બસ થઈ ગયું. Yeah, they were asking some question. What was that question? I didn't hear the question. 11 number. Yeah, someone had asked a question. I couldn't hear the question.
Can you point where area of recurrent laryngeal nerve?
Yeah, sure. Freeze. Yeah. So the area of recurrent laryngeal nerve. See, now here it won't be seen that well because we have done the dissection. If you see, this is the nodule, correct? This is your tracheal groove. So usually this is what we call the danger area, or the area where usually the recurrent laryngeal nerve is located. So we need to create, so what we have done here, this is the nodule, but you see a nice significant rim of fluid is present there to protect the danger area from the nodule when we are ablating. Yeah. Now what we'll do is that 11 number. Keep it on, keep it on. Okay, take it. So now before introducing, we'll just take a small stab with the 11 number blade and see, looking at the lesion, we're going to again go from the medial lateral approach. Ready? Antenna ready? Open છે. Press करूँ? न्यूज़ ने बोला उन्हें. Just setting up the I वो एयर बबल जाए छाम થોડું જવા દો એર બબલ્સ છે આમાં. Okay, perfect. So now what we'll do, this is the antenna. Beta D. Yeah, okay. Everyone can appreciate the nodule on the screen. One second, no? Yeah, that's the antenna. Now we'll enter the nodule. Okay. So now once you enter the nodule, the principle of ablation is what? That you need to mentally choose one direction. That either you are going to go craniocaudal or caudocranial, or you are going to go for mediolateral or lateromiddle. So here what we have done is that first we'll start screening. This is the cranial most portion of the nodule. Then we're screening down, 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 and this is the end. So right now my antenna is in the mid portion. So what I'm going to do is that I am going to get my antenna into the cranial most portion. See, this is the cranial most portion. Okay, can everyone appreciate my antenna? That's the, just show me the finger please. No, with the finger. That is your antenna. The white bright line, that is the antenna. The key of ablation is that you need to ensure that at least the margins of the nodule have to be ablated. Because the biggest risk of recurrence always is going to be if the margins are not ablated. So here now we are on the cranial most tip of the point of the nodule. So what pattern we are going to follow is that we are going to start from the cranial aspect, lateral to middle, then keep sweeping it down, down, down till we reach the lower point of the nodule. Now when it comes to setting, like I said, we keep a setting of usually 30 watts. And when I say moving shot technique means what? First, the moment you start seeing the ablation micro bubbles, that means the nodule has started. So you gradually start pulling it out till you reach the end point of that segment. Yeah. Okay. So now we'll start with the ablation. You will see the white micro bubbles which look like simple terms like a puff of smoke. Jada nigaliye mat abhi please. Yeah, saw that? Yeah, that smoke, yeah, perfect. That is the ablation which is happening. Now as you start ablating, then you need to keep sweeping your probe in a direction so that you cover the entire nodule. As much as possible, try avoiding taking multiple punctures on the skin. The reason being so that lesser the punctures, lesser is the post-op pain. So this segment is ablated. Now we're going to the lower segment. You can see the antenna. The basic rule is that till you visualize the antenna, it is not advisable to fire the microwave. Because even a slightest of shot which is in a non-targeted zone can lead to complications.
So you stop the ablation in between during positioning?
Can you, sorry?
Do you stop the ablation in between during reposition of the
yes, you can stop. So the basic principle, ideally what they recommend, a 30 watts setting, one sphere usually in 5 to 7 seconds, your one sphere of ablation is complete. So if you're well versed with manipulating your antenna into the rest of the nodule, you can continue firing. If not, give it a pause, pull it back, again give the second shot, then again pull it back. Okay. Now this is the lower part of the nodule. Yeah, everyone can appreciate the tip of the antenna. See, the crucial point is to identify the tip. Because that once you identified your tip well, there's a very, very less chance that you will have any collateral damage. So again, we'll start firing. Nigaliye mat, madam. Saw that? So I'm gradually withdrawing it back. After every cycle, if you're not comfortable, keep screening in the same direction which you've decided. Like in this case, we have decided craniocaudal. So after every cycle, go to the cradle most point, check whether it is ablated, and then keeps coming down. Now if you see the point here, how do you identify that the nodule is properly ablated? Is that, freeze the screen please. No, wait, defreeze. Freeze now. The sign of ablation is that you will start seeing these white spots, what we ultrasound-wise call hyperechoic shadows. The moment you start seeing these hyperechoic shadows, that means that zone is completely ablated. Defreeze. And the best part about microwave ablation is that small nodules you can actually finish ablation in less than 30 seconds. So again, now we are at the caudal, the antenna is the caudal most tip. Now we are going cranial. Okay, this is the cranial most point. मैडम आप निकलिए मत प्लीज. So almost the entire nodule is ablated except this small portion here, which we are going to ablate now. Done. Now we'll just quickly screen again the entire nodule, betadine. We starting from the cranial aspect. This is the nodule. Can you see those hyperechoic spots which I'm mentioning? These white things, which represent that zone has been completely ablated. Then you go down, and the entire thing is ablated. You check again medial-laterally also, entire thing is properly ablated. Now, the most important thing is that the most dangerous complication which you're worried about is that you do not want to, by any chance, cause any damage to the recurrent laryngeal nerve. So a simple technique what we do is that we do something called as a laryngeal ultrasound on table. That is one more reason that we prefer to do this procedure purely under local anesthesia, so that in case there is any inadvertent injury to the laryngeal nerve, we can immediately diagnose it and treat it accordingly. So how do you do the laryngeal ultrasound is very simple. In the midline, just थोड़ा पीछे देखिए मैडम, ऊपर देखिए. Yeah, in the midline you see the isthmus and you start going up. The moment you reach up, you will see the vocal cord shadow. Freeze, please. Yeah, this is the vocal cord shadow. If you can see this, can you see this triangle thing? These are your two vocal cords. Now, once you identify the vocal cords, you just need to simply tell the patient to do R and E, and you can see the vocal cord movement. Yeah. Madam, A बोलिए. Oh, perfect. E बोलिए. Everyone could see that vocal cord movements there? Okay. Now, by chance, let's assume when we checked on a laryngeal ultrasound, we see that one vocal cord is moving less or one vocal cord is not moving that well. That means there is a possibility that the recurrent laryngeal nerve is either injured or inflamed or even anesthetized. So what are the possibilities there? One thing is that sometimes when you're giving local anesthesia, the local anesthesia may track posteriorly into a danger area and may lead to transient nerve paralysis. Second thing is that heat itself has led to a transient inflammation of the laryngeal nerve, which is leading to the vocal cord palsy. And third can be, which is the most dreadful, is that directly you ablate the nerve. Now, worst case scenario, let's assume when we check on laryngeal ultrasound, we see that one vocal cord is moving less. So how to bail out is that a very simple way to bail it out. What you do is you take a spinal needle, take very cold either dexamethasone or prednisone on steroid. So if you're taking dexamethasone, take 16 mg of dexa in 20 cc of cold D5. Take your needle, if you feel it's deep, take a spinal needle, enter the danger area with the spinal needle and give that entire thing a rapid shot. So what that does now, that cold D5 along with the steroid is going to reduce the temperature in that area, and along with that it is also going to reduce the inflammation immediately. 80% of your patients will recover within the next half an hour. And as a safety thing, one thing which you can do is that pre-procedure, just half an hour before, see the procedure usually once you get used to it takes not more than 10 to 15 minutes. So pre-procedure, if you want to be very safe, there is a role of IV bolus shot of dexamethasone, which kind of reduces the inflammation and reduces your chances of causing recurrent nerve injury because of inflammation. Now, coming to the post-op protocol, just a routine course, 3-day course of any antibiotic is fine, any painkiller is fine. Usually after the procedure, I give an ice pack application for 5 minutes to reduce because sometimes when you put your antenna, you can have small cutaneous vessels which may bleed, lead to a discoloration. So just apply some ice for like 5 minutes and a gentle dressing. I keep the patient for observation for 2 to 3 hours. If there is nothing, no significant complaints, then the patient can be sent home the very same day. Okay, any questions? Please ask. We'll move to the next case. हो गया मैडम? Perfect. हाँ खोल दे खोल.
So when will you do follow-up ultrasound?
कुछ करो ना, माइक कह रहा है. I can't see anything here. So ideal follow-up ultrasound, so, so the basic, how do we calculate is that there is something known as a VRR, that is volume reduction ratio. Now what is volume reduction ratio is that you calculate the pre-op volume and then you subsequently calculate the post-op volume, and the pre-op, the VRR is calculated as post-op volume upon pre-op volume as a form of percentage to see how much the volume has reduced. So ideal follow-up is usually after 1 month, then after 3 months, then after 6 months. And what we usually tell the patient is that a significant reduction in the size happens only after 6 to 9 months. Now, there are certain criteria which are going to help you to predict what is going to be a volume reduction. First thing is, the more cystic the nodule, more is going to be the volume reduction. More solid the nodule, lesser is, it's going to take more time to have that volume reduction. So there are, on ultrasound, there are certain software, what we call elastography. I think we have that software on the ultrasound machine. So that elastography is basically what's in the ultrasound software, which gives you an idea about the stiffness or the hardness of your nodule. So pre-op ultrasound with elastography, you can calculate the value on elastography. Any nodule which is less than say 20 to 30 kilopascals is a relatively softer nodule, so you can have a little better VRR. Any nodule which is more than 60 kilopascal is a relatively harder nodule, so you will have a longer duration of time required for the volume reduction. Apart from this, like I said, so 1 month follow-up, 3 month follow-up, 6 month follow-up. If you feel that the volume reduction is still not as much as you want, then you can repeat an ultrasound after 3 months again and at the 12th month.
Hello. While you inject the, can you hear me?
Yes, yes.
While you inject the 21 number needle, instead of that, if you use a smaller size needle, I may, for example, 26 needle, is it not that the chances of hemorrhage?
No, sorry, actually I lost the question midway.
26 number needle should be.
Instead of 21 number needle for a local infiltration or creating a plane, you use a smaller needle, say 26 number needle.
So the actual logic is what? So we call it hydrodesection. So what is the principle is that you need to inject the fluid at a particular force, and the fluid has to travel at a particular force to create that plane which is going to separate the structures. So if you take a very 26 gauge, of course you can, I'm saying if the smaller gauge you take now, the lesser is that force generated to separate the fascia. So that's why, but of course you can take a 22 gauge, 20 gauge, however you are comfortable with, but 26 gauge may be a little too small to generate that pressure to dissect the fascia around it, planes around it. Ye the figure.
Last question.
Yeah.
Once, what is, see, all nodules in histopathological may be benign at night, right, this time.
Correct.
But in a later on stage,
okay,
it may turn into malignancy.
Correct, correct.
So how does it affect this technique with the future interpretation of the histopathological technique?
Okay, so I got part of the question. I think the question is that initially when we ablated, the nodule is benign, but what if in the future it turns malignant, right? That's the question.
FNSA you have done, and it's a benign methods at type 2. That's what you have said.
Sorry, I'm not hearing properly.
Okay. Again, can you hear me?
Yeah, now I can hear you.
Okay. In this patient, you have done the histopathological examination. It is Behçet's type 2.
2, correct.
Right. Now, if you do this ablation technique,
correct,
samjho, in a 6 months or 1 year follow-up, suppose, so many tumors, they start with a benign, and later on may turn out to be.
Correct,
so
absolutely
does
correct.
your procedure affects the histopathological pattern of this tumor or not?
No, that's what I'm saying. So let's assume this was a benign nodule, so we ablated the nodule. When we are doing a subsequent follow-up within the first 1 year, along with the volume, there are ultrasound characteristics which help us to tell whether there is any change in the appearance of the nodule. What I think it was discussed outside, the appearance of those micro calcification, all that, which are a sign of something going towards malignancy. That's first point. Second, by any chance, if there is a doubt that okay, this lesion is suddenly growing in size, or there are micro calcifications which are appearing, which should raise an alarm that there is a possibility that a nodule which was burnt has now started to turn malignant. In that case, FNAC is not going to, the ablation is not going to affect the FNAC which was the FNAC which is going to be done. If it is malignant, the FNAC at that time is going to show the accurate result that it is, if it is malignant, it is going to show it is malignancy. The only one thing which is there, na, if the ablation is not done properly, very rarely what happens while ablating, the antenna comes out of the thyroid capsule inadvertently, and those muscles, the strap muscles also get a bit inflamed. So in that case, now sometimes the muscles get adhered to the thyroid capsule. So at the time of surgery in the future, if and when it is required, that at the time of dissection may have some issues to separate that plane. Apart from that, the ablation right now will have no effect as such on the future if it turns out to be malignant.
Any complications like bleed or after the procedure from the thyroid artery?
No, so I'll tell you. So there is something in microwave and RF ablation, when we do RF ablation, which is what we call as an artery first technique. Now what is the meaning of artery first technique is that sometimes when it's a nodule, hypervascular nodule, we see that the nodule is relatively hypervascular with surrounding vascularity. So in that situation, there is the technique of what we call an artery first technique is used, in which with the microwave itself, or if you're using RF, you first ablate that artery. Once you ablate that artery, then you proceed with the ablation. Second thing is, I will not say that there is no risk of bleeding. There is always a 0.5 to 1% risk that there may be some bleeding, but majority bleeding, if it has happened, is usually more common in the skin and the subacute plane. So that once you give a good ice compression dressing, that usually stops. I've had one patient who after ablation developed bruising and like a subacute hematoma. I gave good ice compression, kept the patient on chimodal fort, and that eventually maybe in a couple of weeks it completely settled down.
What are the chances of recurrence?
So like I said, the benign, once you ablate the benign nodule, the first criteria is how well your nodule is ablated. Now, like I said before, the criteria is that you need to try and ablate the margins of the nodule as well as possible, because the recurrence of the nodule will happen if the margins are maybe not completely ablated. So a standard, after ablation, a standard recurrence rate is somewhere believed to be around 5 to 8%. But like I said, in India we don't have a long-term data of years because the procedure is relatively new. In abroad studies and all, they've shown that a recurrence rate is somewhere between around 5 to 8%. Can I wash my hands at least?
What is the cost of the surgery?
That is a very challenging question. So that honestly, that cost is going to keep varying from city to city, because I come from Mumbai where the charges are a little bit higher. In Mumbai, these thyroid surgeries can cost you somewhere around Is my voice audible there? Is my voice audible? Hello? 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 Am I audible now? Hello? Hello, am I audible? Communication system
Hello, can you hear us?
Yeah, now I can hear you.
Yeah. What is the cost involved?
Yeah, so that's why I said, cost now a lot depends on city to city also. Now ideally in Mumbai where I practice, the cost of microwave ablation ranges between say around 1,20,000 to 2 lakhs, depending on the type of hospital, the type of patient, etc. There are insurance cases where insurance sanction has come for 3 lakhs also. So that there are multiple factors. The varying cost, the actual stable standard cost is going to be the antenna cost. Apart from that, the surgical cost, of course, it always varies from, there are multiple factors for that. Please. Get the machine closed.
Hello. Can you give us the detail of second patient?
Yeah, the second patient का details बोलो. वो रेडियोलॉजी कहाँ गए, वो रेसिडेंट है वो कौन है? हाय हाय, नो जस्ट इंक्रीज द डेप्थ एंड ब्राइटनेस, बस इंक्रीज द गेन, इट्स टू डार्क.
हेलो हिमांशु भाई, आवाज़ आ रही है?
परफेक्ट परफेक्ट, गेन गेन વધારે नहीं जाएगा, बस बस.
हेलो, कॉन्फ्रेंस रूम.
They'll only read a guide. I don't need a whole guide. क्या कोई ने कह दो वॉचमैन हिस्ट्री पूछे. Proper colloid nodule, beautiful.
Hello.
Someone is reading the history there. Okay. 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 So tell them to read the history, then we start.
History of the second patient.
I would like to present the second patient's details. She's a 35-year-old female patient with anterior midline swelling since 1 month. On ultrasonography, she has a right lobe of size 13 by 11 by 23 millimeter, in which the size of the cystic mass is 16 by 22 millimeter. Isthmus left lobe are normal. She's euthyroid, and in cytopathology, she has cystic nodule, Bethesda 2.
Perfect.
We'll start with the case.
Okay, so we'll start. Now again, like I said, I always believe it's better to have a fixed protocol of your anatomical screening before you start. So what protocol I follow is that before I start, first thing I always see, of course, see the normal side. Then when I come to the abnormal side, first I identify where the nodule is. Second, I identify which are the structures which are relatively close to the nodule and which need to be protected. So the common, like we discussed in the first case, the common structure is going to be your trachea, your danger area, and your carotid. These are going to be common areas. Now in some cases, what happens? Now, if by chance you have a nodule which is surrounded by thyroid parenchyma itself, like we discussed earlier, the criteria is that you need to have at least 3 mm of a buffer, or 3 mm of either tissue or water between your nodule and your danger and your critical area to prevent collateral damage. So sometimes if you have a thyroid lobe and the nodule is sitting in the middle itself, where it is surrounded by thyroid tissue on all sides, in those cases you may not have to do extensive hydrodissection, just that you need to separate the strap muscles from the thyroid. That's the only requirement which you need to do. Now we'll start the screening. Okay, so the left lobe is fine, the isthmus is fine, and now we're coming to the right lobe. See, this is, point it please. No, that's your carotid. Yeah, come this side now. Yeah, that is your, this is what you call a solid cystic nodule. Freeze the screen. Now here if you appreciate, you can see proper, this is a proper very classical colloid nodule. You can see a hypoechoic nodule, but you can see that it's definitely a thick colloid nodule. Now, since on echogenicity you can make out that this is not a purely cystic nodule, we can safely ablate the entire nodule. Okay. Other thing what you can do now, if by chance you have let's assume there is a solid cystic nodule and you feel that the cystic component is relatively fluidic rather than being colloid. So in those cases what you can do now, you can of course after giving local anesthesia, before you introduce your antenna, you can put a wide bore needle, say maybe like an 18 gauge spinal or a 16 gauge white needle, and try and aspirate the contents. Now what is the advantage of that? Now once you aspirate those contents out now, cosmetically also you get a much better volume reduction ratio. So the cosmetic effect of that procedure is going to be much better. So we'll try that in this patient. If you see this, defreeze. See, this is the solid component, but if you see this component, this is the cystic component. Now there's a chance that it may be thick colloid and we may not be able to aspirate. But in case it turns out to be little on the fluid side, then we'll be able to aspirate the contents and the volume reduction will be better. Yeah? First we'll start with local. Okay, so again the local usually the common approach which I usually take is always transisthemic or middle to lateral. So I'll give local anesthesia here. You can see my needle. Like I said, it's always important to visualize your needle, because this being a very sensitive area, you do not want that your needle has gone into wrong plane and you end up causing collateral damage. Okay, perfect. Now what are we going to do now? I've taken a 18 gauge spinal needle. I'm going to try and put my needle into that cystic component and see if we're able to aspirate out anything. Can everyone appreciate that cystic component? Yeah, perfect. That's the cystic component. Should I needle lagega, madam? Relax. Okay? Now that's my needle into that cystic component. Now what are we going to do? We're going to
I humbly request the students and all, please keep silence. That we cannot hear and the audio is getting poor.
Relax, relax, relax. Huh? See, focus here. Can you see this? Now the advantage is now once you see, you can see the size reduction automatically. Can everyone appreciate the size reduction of the nodule? That entire cystic component has gone. So now what is going to happen now? This is not only going to help us, like I said, it's going to give us a better ablation also, and along with that we are going to get a good cosmetic result. Give me the antenna, please. Now while they are preparing the antenna, we'll just finish the hydrodissection. Okay, now see, that's your nodule and that's the trachea below it. Yeah, that's your trachea. So we are going to, thank you madam, be a minute. Saw that? अभी लोड करने लग गया दोस्त. See. Not going properly. I don't know what to do. Call the audio guy. Ask him what is happening. Thank you. Be a minute. Okay. Now I will separate the carotid. So this is the nodule and this is the carotid. Now in this case you see the carotid is quite close. Yeah? So we will separate the carotid. Yeah. Saw that? That entire area has got separated now. We'll just inject some more fluid there. ઓછો પડે છે. See this. Everyone can see that now the nodule is completely separated from the carotid. So this is the nodule. You are now little bit just the posterior danger area will separate it. Now sometimes getting access into the posterior danger area may not be easy from the lateral or the middle aspect. So there are times where you may have to go transnodular. You may have to put your needle through the nodule posteriorly and then separate the plane. ત્યાંથી બહાર આવે છે. ન્યૂઝને બોલાવી લો ને અહીંયા. ચેન્જ વોટ? કીધું ન્યૂઝને?
Hello.
Yeah. બીજું પોર્ટ ક્યાં જવાનું? તમે અહીંયા વેટ કરો.
Please, I am requesting all of you little bit quiet. પાછળ જે સ્ટુડન્ટ છે એમને રિક્વેસ્ટ કરું છું કે પ્લીઝ થોડું સાયલેન્સ મેન્ટેન કરો તો સર જે કહે છે આપણને ક્લિયરલી ઓડિબલ થઈ શકે. ઓકે, પ્લીઝ.
No problem. ત્યાંથી લગાડજો. So while they are just adjusting the machine, I'll just tell you. So now for image guided ablation for thyroid, there are two modalities which are available. One is like we're saying microwave. Second one is RF, that is radio frequency. Now there are few differences between the two. If you remember, I discussed earlier, the problem with RF is that what happens is that RF tends to go more towards the charring side, so the VRR is not that good. Second, in RF, the patient needs to have those grounding pads because radio frequency works on the principle of generating eddy currents, whereas that is not required in microwave. The third main difference is that when it comes to RF, if you compare the RF antenna ablation zone and microwave, the difference is if this is the tip of my RF, the ablation zone in RF is a circle or like a lollipop with the tip at the center of the ablation zone. Whereas in microwave, the tip is behind the ablation zone like this. So in RF, your ablation is going to go beyond the tip also, whereas in microwave, your ablation usually doesn't go behind the tip. Whatever collateral damage we are worried about is about the heat which is going to may get transferred. So these are the reasons usually where microwave has a slight edge over RF. Sudhu? So at least let me put the antenna till there. No, but then I can't put it. Fluid ઓછું થઈ જશે, પાછું ડાયસેક્ટ કરવું પડશે. કનેક્ટ કરું? let it come first. Use 30 watts करो. तो लूज चे क्या है? ना लूज चे कितने? Better. Okay. चलो hold it. 11 number. So again, see, this is the nodule. Okay, you can see a nice isolated nodule. So we'll take a small stab here. Antenna. Again, like I said the first time, approach is usually standard. So you can choose any, but keep a fixed approach. So I always prefer a craniocaudal approach and go from lateral to medial. Okay, everyone can see my antenna? That's my antenna. Okay, now we'll start from the cranial aspect. See, that's the cranial most portion of the nodule. We'll start firing. Ready? So see, the antenna has gone up to the margin of the nodule, and you can see the ablation happening. Okay, that's the antenna tip. So you can see the cystic components also, the air bubbles are going to travel. That ablation zone, all that cystic component which was there, that is going to get filled with those hyperechoic shadows. See now again, after couple of cycles, you keep screening craniocaudal to get an idea what zone is ablated, what zone is left. Just starting from cranial part, see this zone is ablated, ablated, ablated. This is the part which is pending. So you manipulate the antenna in a way.
Do you look for vascularity to check for the residue?
So ideally, when it comes to vascularity point of view, once you ablate it, those shadows which are there, they tend to interfere with the actual vascular uptake on Doppler. So immediately you may not get an accurate estimation of your vascularity of the nodule. You may get an appearance of the ring, the surrounding vascularity you can assess, but the vascularity of the nodule as such, because of these artifacts, you may not be able to appreciate it properly. So, see, every time when I am screening, I am always screening from cranial to caudal direction. Top of the thyroid, coming down, 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 coming down. So majority of the tissue is ablated, except some segment here posteriorly which is pending. So what we do, take it behind and guide it posteriorly. Okay, this is the segment which is pending. Okay, you saw that bubbling appearance. Now if we screen from top to bottom, again see ablated, 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 ablated. Now since this was a little bigger nodule, we have an ablation time of 1 minute 18 seconds. The previous, show the ablation time here. The previous nodule was relatively smaller, so the ablation time was somewhere around 40 seconds. So that's the ablation. Yeah, perfect. And then indirect ways that while ablating, the patient is screaming or saying, ah, that's a good sign for you that the vocal cords are okay. Okay, I think we're done. Yeah, so final sweep we'll do to screen the entire nodule again to ensure that there are no residual areas which are left. Starting from top, coming down, down, down. Like I said, your marker for your ablation is going to be these hyperechoic areas. Hyperechoic areas, that means that segment has been completely ablated. No, so your area, if you see this small area is remaining. Can you see this area where my pointer is? So we'll have to just ablate that area a little bit. Yeah, this is the area. Yeah, yeah, perfect. Okay, so now we are bang in that area. Start karo, 30 watts. Start. Start. Okay, started, wait. Saw that? Now that area is also covered. Proper. Done. Ice pack application. मैडम आ बोलो, आ बोलो, ई बोलो, आ बोलो, ओके, ई बोलो, perfect. Done? Sure. Just give it a Dexa. न्यूज़ के अंदर बोला है यार मशीन एक स्टेरिलियम लेव कर सकता
The next case,
yeah.
She's a 33-year-old female patient and with anterior midline neck swelling since 2 months. She has in left lobe of thyroid a 30 by 18 millimeter size cystic lesion. Sorry, 11 by 5 millimeter cystic lesion in left lobe of thyroid and adumatoid colloid nodule of thyroid on FNAC.
ऊपर जो ऊपर देखिए खोलेंगे प्लीज. हाँ, दिस इज अ बिग नॉड्यूल. Are we ready?
Yes, sir.
The FNAC has been done. No, reason I'm saying there are big lymph nodes here. So, this is a solid cystic nodule, that's okay, but there are a lot of lymph nodes here. So you want to because આ દેખાય છે આ મોટો lymph node છે અહીંયા પણ ને બેવ અને ઘણા બધા છે એક નથી ખાલી multiple lymph nodes. This is the nodule, see. You see that? So just in case. Okay. So we'll start. Now this is the nodule. It's a solid cystic nodule. That is your trachea and right lobe reaching up to the isthmus. Okay, so the steps remain the same. Now here what are the structures we are going to protect is of course first is going to be a thyroid, and there's a second nodule cranially. This is the first nodule, which is a small nodular. You go caudal, and this is the nodule. So the ideal rule is what, that now even if there are 2 or 3 nodules in one lobe, you can ablate both of them, but ideally never ablate 2 nodules in both the lobes together. The reason is, for example, by chance inadvertently we end up causing laryngeal nerve injury. So unilateral nerve injury, cord injury is manageable, but bilateral injury can be dangerous. So if the patient has, let's say, 2 nodules in both the lobes, then it is advisable to do one lobe nodules at a time, and second lobe nodules after maybe an interval of 4 to 6 weeks.
Thank you, Shan. Everyone please maintain silence.
Chalo, local. Now in this nodule we are going to take not a transisthmic but a lateral to middle approach. No specific reason for that, just that because it seems more on the left side now, a mediolateral approach will be difficult to go ahead with. Payment, just increase the depth because the nodule is big, so posteriorly we won't be able to see. No, increase the depth. Arju ek. Bas. Wait, let's see. Just give me the beater in here. Just beater in here, madam. Okay, now the local part is done. Now if you see here, see one good thing we have here is that just freeze. Now if you can demarcate a nodule, see this is the nodule, right? And here posteriorly there is a thin rim of thyroid tissue. Now one good thing for us is that because there is a posterior rim of thyroid tissue, that itself is going to act like your barrier and protect your danger area. And here also laterally, if you see, there is some thyroid tissue extending between the carotid and your nodule. वागी जैसे मना नहीं लोकल नहीं हाइड्रोडिसेक्शन डिफ्रीज here if you see there's a good margin between the carotid and the nodule. You can appreciate it. That's your thyroid tissue between the nodule and your carotid. So we are okay. As you go down to the lower one, which is a big nodule, see, that nodule is relatively closer to the carotid. Can you see that? We'll separate that. Okay. No air bubbles, please. Okay, you can see the distance with the carotid increasing. Yeah.
Can you hear me?
Sorry?
Can you hear us? Okay. Can you hear us?
Yes.
Okay. Now, it's an open question to you and our Kalpesh, to our professor also here. See, in diode laser, I have seen that needle. Through the needle, they pass a small probe, and at the end of the needle, the projects, and it delivers the thermal tissue, the laser, diode laser. And that tissue is coagulated immediately. So, can the same principle be applied either in this thyroid or in debulking of the tumors, malignant tumors?
Sorry, I didn't get the question.
Kalpesh, any idea? Question you?
No idea. Honestly, no idea. No, I have not tried it. Chalo, hydrodissection more. Your lower nodules, it will not ablate. I'll tell you why. Upper one will ablate. Okay. More hydrodissection. Load control.
In diode laser, it's a small filament that delivers the laser at the end. It can, I have seen that it can pass to the even needle, bend needle also. So the same needle, apply the, here also they apply the same needle. And you pass the diode laser, and laser can be delivered in the tumor. Or in any other cases also, the debulking of the malignant tumor which cause obstruction.
So beautiful dissection.
So can it be applied the principle here also or in malignancy? Yeah.
So 11 number blade.
Energy can be delivered. Hello.
Okay.
Hello.
Yes.
The question is that any energy can be delivered to debulk the tumor or not? That is the question. Not only the microwave. Can you do the radio frequency?
No. So like I said, see, RF radio frequency and microwave is definitely been tried. Laser energy, like I haven't tried it. I'm not aware about it. But if laser, if you're saying that intra-op it is used, then maybe it can be tried. If intra-op it is used for debulking procedures, then it can be tried.
Sir, actually,
the whole principle is that only, that it should not.
Actually, data is there. It is thermal ablation only. So we can use laser, RF, or microwave. All three can be used.
Okay,
the
perfect.
more control is microwave ablation. The laser, you don't have ablation zone control.
Okay.
So if you put a tip at the capsule, it will ablate overshoot or undershoot also sometimes. So laser ablation control is not there. Otherwise, you can do ablation. There is no issue with laser. Data is there. Literature data is there with thyroid also. Yeah, it is there. Yeah, it is very cost effective, but the recurrence rate, like volume reduction rate, is maximum with microwave if you compare all three modalities. Yeah, it is, laser is more time consuming as compared to microwave or RFA also.
Okay. So now we started the ablation of the nodule.
The laser penetration to the surrounding tissue is not bigger than this microablations. Say, I can give you an example. Suppose you do a laser guided arytenoidectomy, right? Or the posterior cordectomy. It requires more than 25 to 1 hour to do that with the coagulations. which has a more power, more penetration in the surrounding tissue, can do
नहीं, आप
this
ऐसा
job
निगलेंगे
within
तो
the
टाइम
15
लगेगा
minutes
मैडम.
only.
हाँ बस
That is
खत्म होने
that
हैं
is the
आप खाली
difference.
थोड़ा वो कंट्रोल में रखिए.
Now the question is, in the debulking of the tumors, in the debulking, suppose the laryngeal obstruction, it's inoperable, something like that, advanced stage, whatever may be. The present symptom is dyspnea or exertion or stridor, whatever may be. So can it be, can this energy can be delivered? See here laser in direct, we have got a laryngeal control directly. We can see.
The ablation.
There is no need even ultrasound also.
Hello.
Of course, you can do with the ultrasound also.
Dada.
But see the see the tumor, laryngeal tumor, whatever may be. Then you can deliver the energy and debulk the tumor to make the symptoms patient little bit symptom free. Can anybody else tried and seen the result? What I am asking you.
Sir. Sir.
Laser can be immediately destroyed and the things we will reduce the edema and debulking the tumor.
Sir, we have done
Laser will not give result after 6 months. No, it's not like that, I think.
Immediate result is seen, sir. Sir, we have done one case of papillary CA who is having recurrence in the thyroid bed as well as nodal metastasis. Patient was having severe intractable pain because of nerve involvement in multiple areas in the neck. So, sir, in this case, we have done 2 sessions of ablation. One was microwave ablation. Patient had significant pain relief. Patient himself came back to us and said, I want another session of ablation. That time, due to cost constraint, we did alcohol ablation in the areas where there was infiltration. And patient is having significant relief. As such, he was a recurrence case and he was on conservative medical management, best supportive care.
They had nodule? That's your antenna, which is in the nodule time. Okay, and we are at the margin.
Pain, sir. He has coming for pain.
Hello.
Yeah.
There is a question that this microwave, how much the calorie, that is the temperature will generate on ablation of the tissue?
It ranges between around 80 to 100 degrees.
Okay. So we have a discussion there, the laser have a more temperature than the this microwave.
No,
so the tissue edema will be more with the laser.
More than tissue edema, na? See, like I said in the beginning, the principle, the main reason for doing this along with the, we want is volume reduction of the nodule, correct?
Right.
Now, when the temperature, see there are 2 entities. One is what we call coagulative necrosis and second is what we call charring or carbonization.
Okay.
Now, our aim is to reach at the level of coagulative necrosis, not charring.
Okay.
The reason is because if you're causing charring, then your macrophages are not going to eat up that charred tissue and your volume reduction is not going to be there. And on the other hand, if you're doing coagulative necrosis, the principle of coagulative necrosis is that your macrophages and your immune system is able to digest that tissue. So that's how you get a volume reduction.
Okay.
Hence, it is advisable to keep the temperature less than 100 only because it's believed that above 100 it leads to charring.
Okay. So we have.
So maybe that is the reason why laser is not done.
Okay. So we ENT people are very fond of using coblation. That is a cold ablation. We are doing lots of surgery, tonsil adenoid turbinoplasty like this.
Okay, okay.
Where the temperature is hardly 60 degree.
Okay.
So can it be used here?
Okay, perfect. Laser probe of the goblet. I have no idea. Okay, so this nodule is done. Can you see? Again, the protocol remains the same. Start from the cranial aspect, go down, ablated, 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 ablated. Okay? Madam, A bolo.
Hello, hello.
Perfect. Yeah. E bolo.
You have seen the
vocal
cords nicely you have demonstrated. Yeah. Suppose there is a large laryngeal tumor.
She was the happiest of all 3.
Can you hear me?
Arre ho gaya Benji.
Can you hear us?
Yes, yes.
Okay. See, you've seen you demonstrated nicely the vocal cords and its movement.
Yes.
Suppose in the laryngeal tumor,
Laryngeal?
yeah, laryngeal tumor.
Tumor, okay.
It is say inoperable or age and other factors.
Okay.
And there are lot of stridor and other things.
Okay.
So airway obstruction.
Okay.
So any experience with that tumor with this technique, tumor ablation?
No. So when we do microwave, so we do microwave ablations along with the thyroid. For malignancies, we do microwave ablation of, say, liver tumors, liver metastasis, lung, RCC, etc. But are you referring to direct ablation of the laryngeal tumor using this?
Have you any experience with this?
No. Laryngeal tumor, I've never ablated with this.
I share my experience. We have lots of patients from the GCRA institutes. They get admitted over there with the stridor. They diagnose that this is the tumor, adenocarcinoma twice. So they have a plan for resection anastomosis that we cannot do, they are going to do. But before that, they get it for the surgery on the table, they send it the patient to us. So with the coablations, our conventional coablations, I have reached there, transglottic, and we have dissected out, so that they can get time, and meanwhile they can operate it.
Kalpesh, we have taken fourth patient.
Yeah,
go ahead. And speak PPT of the fourth patient.
Okay.
No. That mode, no. Keep vascular mode. Change this mode.
The fourth patient is a 31-year-old female who presented with midline neck swelling since 1.5 months, and in right lobe of the ultrasound, in right lobe of thyroid, she has a approximately 2 by 3 centimeter size cystic lesion. The left lobe and isthmus are normal, and cytopathology is benign cystic lesion.
Okay, so now we'll start this nodule. See, this nodule, our plan is going to be a little different. I'll tell you why. Because when we screen, see, as per protocol, first we screen the normal side, it's okay, nothing to worry. Then we come to the left side, which is the abnormal side. See, if you appreciate this nodule, it's a predominantly cystic nodule. You can say at least 85% of the nodule is cystic. So here, what our plan is going to be, we're going to put in a needle, we're going to aspirate the contents out. Along with that, we are going to inject what we call a sclerosant into it. Now, in a predominantly cystic nodule, along with angina, along with ablation, you can also just aspirate the contents and inject a sclerosant. You can use cetrol, you can use absolute alcohol, whichever is available to you. And for the once the size has reduced significantly, then you can just the margins, you can ablate with your microwave antenna. Local. Madam, थोड़ा पीछे ऊपर देखिए और. Perfect. Okay. So we'll give local anesthesia. Spinal, and just load that cetrol. One should be okay. Yeah, so now we are going to put the needle into that cystic component. Zyada nigali mat benji. Okay, you can see the entire, everyone can see the needle tip in the center of the nodule. Perfect. Now we'll aspirate the contents out. मैंने bubble ने जोता अंदर.
How will you decide how much to inject?
So ideally what we recommend, any nodule which is say less than around 2 centimeters, 2 ml of cetrol is enough. And at the end of the day, see, along with this, we are also going to ablate the margins. So now we just appreciate the size reduction. See, everyone can see the needle in the center of the nodule. Betadine.
So after injecting cetrol or alcohol, you will ablate the
margins. Yeah. So if it is a pure cystic, there are no solid components, then you can just manage with alcohol and cetrol. There is no need for ablation. But if you see here, can you see this? If you see the freeze the screen, freeze please. The lower aspect, see, can you see the lower aspect here?
Yes,
These are all the solid, like a relatively solid components. So that will not respond well with your cetrol. Defreeze. Okay. Now we are in the center, and now just see the, appreciate the size reduction. So if you see the contents here, they are not, maybe they're quite actual colloid and viscous, so you're not getting that much of aspirate. Even after using an 18 gauge spinal, you're not getting that much of aspirate and size reduction. So which means that rather than purely cystic, it's more like a colloid nodule only, which is
You could not aspirate 1-2 ml also?
No, we've aspirated 2 cc. You just focus on the, aya focus karo. See, can you see the aspirate amount?
Yes.
Yeah, so it's hardly to, and that too with a 10 cc suction, and we are bang in the center of the nodule. So now I'm just entered in another component. So see here you're getting some as fluid. Can you see the size reduction happening? Can you appreciate the size reduction?
Yes.
See this. And now see the syringe also, we got around 6 ml of 6-7 ml. Now what we'll do, we'll take this, we'll just take the cetrol here. This is the fluid which has been aspirated. Cetrol. Cetrol here. If absolute alcohol is available, that is also a good option, but that is usually not available everywhere. Okay, you can see my needle tip. Now I'm going to inject cetrol. Saw that? Now cetrol has filled the entire cavity. Now what are we going to do is that, take this out, and now we're going to ablate the solid component. So 11 number blade. Gauze piece. Beta dip. Aya muki do. गाड़ी में sorry, अच्छा, you've not attached it. Attach it up then. Meanwhile they're attaching, we'll just finish the hydrodissection then. Now see here, hydrodissection simple. Posteriorly we are not that bothered. If you see posterior, there's a nice rim of thyroid. Here the carotid is quite close. Can you appreciate that? So we're going to separate the carotid. Yeah. Okay, saw that? Carotid got nicely pushed away. And then last will be the separating the trachea. Okay, saw that? Luckily even the posterior got separated more. We got a good plane. Chalo, take the antenna. Two minutes. Okay, can you see this? Now we are in that exactly on the periphery of that solid component. Yeah? Foot pad kya hai? Bas. So now we'll start the ablation. So all that entire solid component which is there, we are going to ablate it. We're going to start from here. Okay?
Do you pierce the capsule and go further because the microwave active zone is 2 millimeter?
No. So we just gently abut that. We don't pierce the capsule.
Because the ablation active part is
correct. So
2 millimeter beyond.
Yes. So we just you can gently say just abut the capsule, but no need to pierce the capsule as such. Sudhaija. See, now we're again starting as protocol, craniocaudal, ablated, 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 this part is remaining, okay? So now we'll guide our antenna into this part. Okay, so now we are in that component. Swallow nahi karo.
Hello? Hello?
Yes.
Sir, what is the success rate?
Sorry, what is the?
Success rate.
Yeah, so like I said, now if you're talking about volume reduction, you achieve in terms of success rate, we talk about VRR because that is the main reason. So we achieve a volume reduction of up to 70 to 80% is expected after a period of around 6 to 9 months.
Okay, but ultimately this is not a curative therapy.
Curative as you see benign nodules, like I said in the beginning, now see the microwave ablation is not a replacement for a thyroidectomy or a hemithyroidectomy. It's, start the machine. It's basically like an additional treatment option which is available for the patients who either are not willing for surgery, who don't want surgery, or maybe not fit for surgery. So when it comes to a benign nodule, if you're talking about complete curative nodule, see the tissue is around, like I said, the recurrence rate is only around 5 to 8%. So 5 to 8% chance is there that the nodule may recur again. But as such, the nodule is after that is going to be scarred and gone. But yeah, if you talk of success in terms of size reduction, that has a VRR of around 70 to 80% by around 6 to 9 months on an average. And like I said in the beginning, more solid the nodule, more time it's going to take to for volume reduction. See, again we screen from top, ablated, ablated, ablated. Now this is the only component which is remaining, the lower pole. So now we'll direct it accordingly.
Hello.
Betadine. Yeah.
Yeah. My another question is
yes.
To you and to our professors also here. What is the etiology? See, we see many patients who are asymptomatic, but accidentally on the sonography you find a small nodule. Maybe some percentage of the population also you find. So what is the exact etiology of this thyroid nodule? Can anybody throw the light? Anybody from the audience also please answer.
See, it is any nodule, it is malignant or benign. Most of the common cause is multifactorial, mostly genetic, followed by environmental factor, diet factor. So pathogenicity is multifactorial. It's not a single factor which leading to benign or malignant lesion. So it is mostly multifactorial.
I think the hormonal changes is responsible. More you will see the female is almost 80 to 90% thyroid nodule you will see, sometimes accidentally or sometimes symptomatic. Hardly will see the male patient having a thyroid nodule. And we see that if patients have a thyroid nodule in the male, chances of malignancy is more than the female.
And iodine intake also. It's depend on iodine intake.
With the universal iodization, I think it's not the etiology factor, except in some Himalayan or some endemic areas, probably.
Done. See, you again start screening from.
Can anybody suggest any preventive aspect of this nodule? Kalpesh, Atul. Can anybody suggest the preventive aspect? Say this is a widely prevalent. So can we do the things preventive? I'm asking about P and SM question.
Exact etiology is not known, how can you prevent? Because once you know the etiology, then you can prevent and avoid something.
See, universal iodization of the salt is there.
All physiological, I think. It's not the pathological. Sometimes the physiological changes occur in the body and that maybe reflect like this, adenoma. There are so many things in the body which is going on, you don't know.
Patient asks us, sir, why this nodule has occurred? To me. Patient asks us, sir, Manoj came through.
But it stopped, but it just did it.
Sir,
हेड थोड़ा कंप्रेशन આપી રાખો ને સાહેબ બસ બીજું કાંઈ નહીં એક મિનિટ
हेलो
તમને પાવડરની એલર્જી છે
any nodule more than 2 centimeter, it is whether benign or malignant. Minimum treatment is hemithyroidectomy. If less than 2 centimeter, no treatment is required. If it is benign lesion.
Fifth case, yes, sir. Tell them you're starting the fifth case.
Kindly give us the history of the last patient.
So what will have to do?
The last case is about a 32-year-old female patient with anterior midline neck swelling since 1.5 months. On ultrasonography in right lobe of thyroid, she has a cystic lesion of 48 by 26 millimeter and isthmus left lobe normal, cytopathology cystic nodule of thyroid.
So what we usually follow, na, any lesion which is usually more than 4 centimeters, they are not very ideal for microwave ablation. Why? Because A, they may require multiple sittings. However, if the patient for whatever reason is not fit for surgery or not willing for surgery, then this option can be offered. Now see here, if you see, na, the left lobe is fine, but the right lobe has got a big, the right lobe has got a big nodule. Can you see that? Now sometimes what happens, now freeze the screen, please freeze. Sometimes what happens is that because the nodule is little big, we may not be able to achieve a good hydrodesection posteriorly to protect the danger area. Now in that case, of course we try, but if you are not able to achieve, then what we have to do now, we have to leave that peripheral rim of the nodule and not ablate it. What happens, what we call piecemeal ablation, you leave that zone, leave that posterior portion and ablate the rest of it. Now over a period of time you keep a follow-up, and once the nodule starts shrinking and you feel now there is a good plane where you can give a good dissection, then you can proceed with the next sitting. So here if you see, it's a big nodule, so what we'll do, we'll try and see if we can dissect the posterior area also. If you're not able to achieve, then we'll just leave that peripheral part and ablate the rest of the zone. Now coming to the what we just discussed, if you saw the previous case, it was predominantly cystic with a small solid component, while here it is predominantly solid. So the volume reduction of that patient is going to be much better as compared to this patient. Defreeze. 2 minutes. Hurry up. So I will start the dissection. Huh? D5 है ना? हाँ बस D5 जो है. Here we'll first separate the carotid. एक मिनट लाइट काढो नहीं. Saw that? Okay, so now we have separated the carotid safely. I will try if we can separate the posteriorly, or we will have to leave that zone. एक depth ओछी करना, વધારને depth थोड़ी. बस. Yeah. Like I said, see now if we don't have a good plane, one is of course to go this way if you can get entry into your posterior area. स्पाइनल नीडल दो मेरे को, स्पाइनल नीडल, स्पाइन सलाइंस आते हैं. चाहिए. So this time I am going transnodular to see if I can reach the posterior area and dissect it properly. वो swallow नहीं करो वो नीचे जा depth વધારે yeah no I'm not able to get that so we'll not do it antenna chal we'll start the ablation. So like I said, in this now there is no way we can reach the danger area directly. I mean we'll have to, so it's better that the peripheral aspect antenna બધું connect કર્યું 11 number blade. Start from the cranial aspect, cranial, so first we swallow नहीं करो. So we are starting the ablation now. Don't swallow, madam. See, the whole key is that you should ablate the margin very well. So that's what we are doing. You see, we are ablating the margin of the nodule. Swallowing at the right time only. See, because it's a big nodule and a solid nodule, we will require a little longer duration of ablation. Perfect. Betadine. So I'm leaving that posterior rim. If you, you can see, I'm leaving that posterior rim of that tissue. Okay, again now we start screening from top. This part, the top part is remaining, so that we'll ablate now, and then we'll move caudally. Okay, see, that's your cranial most aspect. Now we start again screening from cranial to caudal. Topmost portion, ablated, ablated, ablated. Here the lot of tissue is remaining. So here now we'll direct it. See, the key is that you have to manipulate the probe in a way that eventually you sweep and cover your maximum area of the nodule. Yeah, you can see that. Sometimes, if there's something what you call as a sticky nodule, the colloid while you're ablating keeps getting stuck to the tip of your antenna, which was happening right now. So because of that, your ablation won't be that good. So in those cases, you may have to actually remove your antenna and reposition it again and again. Yeah, now it's good. Okay, again craniocaudal screening. Ablated, 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 ablated. Now this caudal part, this much part is remaining. So we'll okay. Coming from top, ablated, 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 ablated. Now this is last. See, this is the last segment which is remaining. So we'll now guide it. Okay, antenna. Yeah. So hold it. Gauze piece. We'll start screening from again top. Okay, ablated, 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 ablated. If you notice the posterior rim we have left, freeze the screen. See the posterior rim here that we have not ablated because like we had decided, because in this case we are not able to get the plane dissected below because the nodule is very big. Defreeze. Superb. Done. Madam, A bolo, A. Okay, E bolo. Perfect. Chalo. Thank you.
Thank you very much, sir. We thank you sincerely for such a beautiful and wonderful demonstration.
Thank you so much.
Dr. Monil sir and Alpesh sir will be coming out from the surgery. If you have any more questions, you're free to ask them. We also extend our sincere thanks to Eco Microwave Ablation for providing us with this opportunity. They are pioneers in microwave ablation field and have revolutionized the concepts of minimal invasive therapy. We also thank the AOI Ahmedabad, the President and the Secretary AOI Ahmedabad, to the Superintendent of the SCL Hospital. We also thank the Radiology Department and the Anesthesia Department, our Sir Dr. Sorin Panchal sir, for their kind support in helping us organize this event successfully. We also thank the faculty and residents of ENT Department, SCL Hospital, playing a major role in organizing of this workshop. We're just waiting for the sir to come here. He'll be coming here.
Thank you, boss. Thank you so much.
I would like to ask Dr. Alpesh sir to please felicitate Dr. Monil sir with a flower bouquet. Thank you, sir. Okay. You can go ahead with the questions to ask.
Please. Any experience with the sclerosant that you injected? It's a 100% alcohol. What you inject? Cetrol. How much? 2 cc, how much? Mike, please.
So it's basically sodium tetradecyl sulfate. It's basically a sclerosant. So we commonly use it when we do our varicose veins procedures, lasers. We also do it for those low flow hemangiomas or AV malformations. It's a sclerosant. So ideally, absolute alcohol is better, but that is usually not available. Because for that, apparently you require some permission from the patho people and all that. Cetrol is very commonly available. So usually what we follow is that any nodule which is around 2 to 2.5 centimeter in size, one vial which contains 2 ml cetrol is enough. If it's a bigger cystic nodule, then maybe you go with 2 vials.
After injecting, what is the problem that you are facing? I mean, morbidity or whatever, pain?
No, nothing pain as such. The only thing is, for example, if it's a pure cystic nodule, like for example, the 4th case we saw, it was predominantly cystic, but there were those solid frands kind of a thing. Now, in that case, if you have done only cetrol, see how cetrol works is that it's going to line your intima of the epithelial layer of the cyst, and it's going to cause necrosis of that. And so the secretion and the production of that fluid is going to go down. That's how cetrol works. If there is solid component, and if you put only cetrol, then that solid component is going to keep throwing out fluid. So your nodule is going to 100% regenerate. So, yeah.
In 85% cases, you have seen it's only cystic.
No, I said
cystic goiter.
No, that patient had 85% cystic component.
Component, yeah.
So that nodule, I mean, I don't have a ratio as to which nodule is how much cystic and all. But like for example, today we saw the entire spectrum. We saw banked solid nodules, we saw solid cystic, we saw predominantly solid with cystic component, we saw the other round also. So that usually varies everywhere. The whole thing is the solid component you have to ablate. There's no choice about it. The cystic component you can manage with cetrol and alcohol or absolute alcohol. We can do that. No, we can do that. See, the whole advantage is what that whenever we inject cetrol, see the principle, what is the bottom line of a treatment, that he wants that intima lining to be dead so that it doesn't throw out more colloid or whatever it is. So when you inject cetrol, plus you are ablating, so that cetrol is also going to line the intima, so maybe out of 100 epithelial cells, 30, 40 will be taken care by the cetrol and remaining you are ablating. So you can do that, no harm in that.
But see, all doesn't have a sonographic control. So while we do the FNSC, we aspirate many times.
Correct.
And once you aspirate, so we see the immediate reduction of the size.
Correct.
So at the same time, is it possible to inject cetrol?
100% you can inject at the same time.
Yeah. Without sonography, because all does not have.
See, without sonography, I don't recommend. I'll tell you because, if you don't have ultrasound, you don't know whether it's purely cystic, solid cystic, what it is. So you may be able to aspirate that cystic component and you may inject cetrol that. But that's not going to treat the nodule, right? Because if, for example, if it has a cystic solid component, that cetrol is not going to solve the purpose.
But at least cystic component is, you inject the sclerosant, so cosmetically patient definitely feels better.
Little bit, yeah.
Definitely.
Yeah. And again, that depends on how big the cystic component is.
Yeah, how big is cystic component?
Yeah.
Complication rate of blind procedure may be little bit higher than one of a guided procedure, because if cetrol extravasates or alcohol extravasates from the nodule outside the tissues, it can cause some scarring, pain and discomfort to the patient.
See, the biggest challenge is what, at least in Mumbai where I practice now, even medico-legally, if your institute or your hospital has an ultrasound machine, if we do a procedure blindly, if your institute or your hospital has an ultrasound machine, one person may or may not know how to use it. That's a separate issue. But if a procedure which is safer for the patient, image guided, then medico-legally if you do it blind and something goes wrong, then we can be in trouble. Be it a pleural tap, be it anything. So I always recommend, see wherever I go, I always recommend that it's always advisable to have a radiologist or an IR with you until you are confident. If you feel you are confident, then it's okay. But if you're not confident, it's safer to have an IR or a radiologist with you, always. Yeah, so I'll tell you how it happens. For example, you puncture, you aspirate out everything. It's a 6 ml nodule, you have aspirated entire cyst out. by the time you remove the needle, you load the cetrol, you attach your syringe to it, your needle tip can come out, the bevel may come out. And trust me, cetrol into skin necrosis is very bad. I'm sure you must have seen. Cetrol into skin necrosis is bad. Bad as in you will get a proper black display and the skin will fall off. It's an ulcer. There is no question about it. And you can't do anything, yeah. And you do whatever, it's not going to heal. It will require a proper debridement, regular dressing. Worst case scenario, in lower limb at least, you may require skin grafting. So a rule we follow is that whenever you're injecting cetrol, until you get free flow of the cavity in which you're injecting, you don't inject cetrol. Because cetrol extravasation is nasty, very nasty.
What is the time for the cycle of single micro? 5 seconds? 7
So I'll tell you. So ideally how it works now is that the setting you keep is 30 watts. Now what they recommend is that one sphere of ablation which you want to achieve, that usually is achieved by 5 to 7 seconds. But now see, once you do more and more cases now, you get an idea, you get a hang of, okay, this nodule, maybe it's still solid, so rather than keeping for a 5 second, maybe you keep it for a 7 second. And how to control. Now one more thing now which I have, I do it, it's a new technique, is like, I do something known as sweeping. What do you do? Like for example, it's a relatively big nodule. You are ablating everything, you're ablating the piecemeal. At one point now, once you feel that, okay, majority part is ablated, you're about to end. Majority part is done and you're about to end the procedure. You get the nodule, the antenna in the bang center of your nodule, and you can gently manipulate your antenna in a way that you can sweep your entire nodule. So what that is going to do now, that is going to ensure that if there is some small component which is left back, that is going to ablate that also. Ideally what we follow is that 30 watts, 5 to 7 seconds, you get that good microbubble appearance, you start withdrawing. Now the last case we did, that nodule was very, very sticky. So even after keeping for 7 seconds, I was not getting that, that microbubble appearance. So in that case, you need to just take out your antenna, clean it, maybe some gunk which is stuck, put it again and then do the same cycle. Simple logic, more solid the lesion, the duration has to be on the higher side of the spectrum. See, again I'm telling you, the recommended is 5 to 7. If you feel, one more practical point I'll tell you, if your antenna is ETO'd, reuse, then you may have to do that also. Because with more and more reuse, the eventual efficacy is going to go down eventually. So what you see on ultrasound, if you see that your bubble generation is not good or not adequate, then you can go up to 8 seconds, 9 seconds. They recommend 40 watts. I don't do 40 watts, I'll tell you. How watts work is that the higher the watts, the more is usually the lateral spread of your energy. I'm sure you must have done microwave for liver and all that. That's how it works. The more watts, more energy, more is the lateral spread. So in that case here, you don't want the lateral spread. You want to keep your ablation zone as restricted as possible so that you don't ablate the surrounding areas. That's the thing. Absolutely, yeah, absolutely. Because you have more energy, more heat.
How many times you have seen that there will be excessive bleeding sometimes where you have to do intervention some?
Yeah, so till now I've never had a patient I had to do an Hydrodesection. One patient, like I said, one thing now which can happen, see, you're playing very close to the carotids. So by chance, while even giving tumescence, and sometimes you may inadvertently puncture once in a while, it happens. So immediately you will start getting that, what in ultrasound now you see a pericarotid hematoma. Just give gentle compression, that's it. Very rarely it's going to happen that it's going to go out of hand. The simple reason being majority of the thyroid nodule is going to be relatively younger patients, relatively, I'm not saying all patients, so who are relatively fit. So very, I will not say rare, unlikely, but few patients who are old and who have comorbidities, then of course you need to be very careful. But younger patients, things are better. Things are more suitable for us to do it.
Multiple nodule, how many nodules at a time you will do the?
Yeah, so see, what is the ideal recommended guideline is that whenever there is, let's assume there are 3 nodules on the right side, 3 on the left side. The bottom line is you can ablate n number of nodules of the same side, but you can never ablate both the lobe nodule in the same sitting. Because like I said, see, you're always worried about your recurrent laryngeal nerve. So if you by chance inadvertently damage it, one recurrent laryngeal nerve is gone, is okay. But if both the laryngeal nerve get paralyzed simultaneously, then you're in trouble. The patient can have bad stridor and then you may have to intubate or whatever. So one lobe can have 3 nodules, you can ablate them, no problem. But again, when you're ablating multiple nodules, you need to be very good with your hydrodissection. Why? You have dissected nicely, but by the time you finish the nodule, majority is going to get absorbed. So you may have to keep doing it again and again. So in those cases, better to put like a colloid, you know, like a hemacele or something which stays there for a longer duration. So you don't, even if you take time, it's going to stay there.
So you're told that that the largest nodule you can ablate is a 4 centimeter,
Ideally,
right?
ideally.
But what is the smallest you can do?
Smallest, see the criteria for smallest is what? Ideally what they recommend, any nodule which is less than 10 mm does not require treatment. Of course, its subject has to be benign. On ultrasound, if you're seeing there, what we call Tyrad's classification is benign. You do an FNA, it's showing benign, then you don't need to treat it. A nodule, what is the indication to treat a benign nodule is A, it's causing some symptoms, B, cosmetic. These are the two common indications. If a nodule less than 1 centimeter, very unlikely to be cosmetically ugly and very unlikely to cause symptoms also, right? So just keep a close follow-up. If you feel that it is increasing in size, then you can always go and just burn it out.
That the patient's intelligent, having a sonography as the nodule, so they usually ask what to be done. That's why I'm asking.
No, so you give them the option that this right now nodule doesn't require ablation. If you want to ablate, you will ablate it. Patient's wish.
Any experience with the viewer or in audience? People are, first you advise surgery, people usually reluctant. They oppose always.
Correct.
So they ask for any medicines that you want. So any experience with the thyroid hormone replacement, 100%, 100 microgram, and suppress the thyroid.
For the nodule?
For the nodule, yeah. Say, it is being said, it is not now much.
Like, I don't have an experience of that. Maybe someone
That
else
is what
can.
I'm asking the audience also.
Okay,
yeah, I have put the question to audience also. Yeah. So any experience with the thyroid hormone suppression on a long term, maybe 3 months, 6 months audience. And if you get any result, any experience with that?
No,
that
no,
is what
as such, I have no...
Alpesh, anybody? Vassal? Yeah.
Sir, if the patient is euthyroid, right, and whatever like FNAC or a USG, thyroids or Bethesda suggest you a benign lesion. If the patient is euthyroid, there is no point in giving any thyroid replacement therapy. It's not going to help. Either you... But already it is euthyroid, then how can you suppress? Yes, sir. So, you mean to say you want to make the patient hypothyroid? But that is not only the etiology of developing goiter within thyroid follicles. That is not the only etiology, developing the thyroid follicles into goiter. So whenever there is a swelling which is benign or even if malignant, there is no point in giving thyroid suppression if the patient is euthyroid.
Agreed. Out of compulsion also, I have tried in a few patients and many, quite good number of people, see after 3 months or 6 months, they say cosmetically they are definitely better. After 6 months or 1 year, if you do the sonography and the sonographically it is proved that the size is reduced. That is what I am saying. Say any experience like me with any other people. That is what I am asking.
Medicated hyperthyroid. So what are the complications you come across with the hyperthyroid? That the patients have a tachycardia, palpitation or something. That is a thyrotoxic. No, TSH will be automatically down because you are supplementing the thyroid. So patient become thyrotoxic if you supplement thyroxine 100 milligram, which is a euthyroid patient.
Sorry, what is the treatment of? No, so you're saying that cosmetically swelling has not gone down? No, the nodule is not going to disappear, right? When we ablate it, like these nodules,
They will shrink in size, but they are not, your volume reduction is never going to become zero. Your nodule is not going to disappear. They are going to become maybe fibrous and they're going to shrink in size and stay there. If you can do reablation, of course you can do. For example, I tell you, we do a nodal ablation, everything is cool. After a year or so, patient says, I'm feeling the swelling again. You do an ultrasound, you'll get an idea about the comparison of the previous size. If it's a doubtful, you're suspecting, even if it's not suspecting, you have to do an FNA to confirm that it's not a malignant transformation. If it turns out to be benign, ideally they recommend 2 FNAs. If it's a benign thing, then you can ablate again. There's no harm in ablating that. Only thing is, one thing I had read up now, that if you do multiple ablations, that eventually leads to a lot of adhesions if in the future thyroidectomy is to be done. 1 or 2 won't, but if by chance 2, 3, then that becomes an issue. That I don't know how adhesions affect, maybe he'll tell you better, but I've read that it leads to adhesions because you keep puncturing, keep ablating. Till now, actually, no redo because I've started doing only 6-8 months ago. Yeah. So till now, there's not been. No, I have done around 80 cases. Yeah. No redo till now. Except one redo, I would say it was just a small cyst, around 2 centimeter cyst. I didn't do the ablation, it was a pure cyst. So I put a little aspirate, put cetrol. That lady, at that time, it was totally collapsed, gone. But maybe after a few months, she did have some swelling. So I did USG from 2 centimeter, that cyst was there, but it was around 1.2 centimeters. So I didn't do anything, but if you can technically call it a recurrence. Microwave? Yeah. So ideally, see, if you see the last case nodule was I think around 48 mm. If ideally, I always say any lesion more than 4 centimeters is not an ideal case. In that case, thyroidectomy is definitely an ideal option. But if patient is, you want to give it a try, in that case what happens now, the bigger the nodule, the more difficult it gets to dissect, especially the danger area. In that case, you will have to do a piecemeal piecemeal ablation. You will have to ablate maybe around 80% of the nodule. The peripheral part you will have to leave because you can't go down. What happens, it will shrink. Now let's assume after 9 months it shrinks to around 60%, for example. Because it has shrunk to 60%, now you have a good window to do a good dissection posteriorly. So then you can ablate the residual nodule also, what we call piecemeal ablation. That you can do. So correct. Yeah. No, so no, that is there. That is what a literature. Yeah. No, that I don't remember. That I don't remember. That talk I'll leave to Neesh, he'll take the talk. No, so what happens, I'll tell you. The actual, I'll tell you. No. So see, the main cost actually is of the antenna. So a new antenna usually costs somewhere between, I think, around 90, 85, 90, yeah. And if you're using a reuse antenna, that varies between, I think, 30, 40, whatever. So I always say, I practice in Mumbai. Mumbai, what happens, medical care is very expensive. I have done cases where I have charged the patient 2.5 lakhs also. I have done cases where I have charged the patient 1 lakh also. So that again varies on what kind of hospital you're operating and in that scenario. So ideally, your actual cost is going to be only your antenna. So once your antenna cost is fixed, then you can give the package as per your standard, whatever the criteria is. In Mumbai, usually microwave ablation ranges between 1 lakh to 2.5. That. Correct. That. Correct. I agree.
Which
which are the other indications in thyroid adenoma? Cystic swelling. Anything else thyroid where you are applying this microwave? Suppose there is a Hashimoto thyroiditis or there is a goiter.
Yeah, so I'll tell you. So what happens now, in the actual indication of microwave is mainly for your nodules only as such. Now there are some studies now which are showing that even in a overall bulky Graves, like a big nodule, you can do just a, I have not done that. I have read somewhere that you can do a thyroid tissue ablation, kind of like a volume reduction surgery. Now apart from this, as IR we also do something, it's called TAEGR, T-A-E-G-R. That is thyroid artery embolization for goiter reduction. But like I said, for microwave, I don't know whether you've done, I've never done for volume reduction. No, not embolization, I'm talking about the microwave ablation. Embolization I've done. Yes. That I have not done, but there are articles which show that even for a bulky thyroid, you can just ablate the normal tissue for your volume reduction. Because see, the principle remains the same. You want volume reduction, so you ablate a nodule, it's going to shrink. You ablate thyroid tissue, it's going to shrink. So I have never tried that, but there is literature which shows that it can be done. Yeah, any day better. Yeah.
If there are two different nodules, in one right lobe of thyroid gland is solid lesion, and in left lobe of thyroid there is a cystic lesion, then what will be your first priority for the tumor ablation?
Always solid.
Solid.
Always
okay.
Solid. Always solid.
We are not sending the material for histopathological examination, and after 6 to 7 months, if recurrence is there, and if you find there is a malignancy, if you suspect, then if there is any medico-legal probability.
So before you take the patient up, you have to have an FNAC done. Ideally, what they recommend is that you need to have at least 2 FNACs from 2 different people to be doubly sure. So if you do that, then see, you have documented evidence that when you ablated, it was benign. Correct? You have documented evidence that when you ablate, it was benign, right? So then later, in the future, if it turns malignant, so many people, like for example, GI surgeons, all they operate. Everything is okay. Within 6 months, they can have recurrence. Bad luck, no? So you can't, if you have a documented FNAC evidence saying that it is benign, it's benign. Then nothing to worry. Then you can safely ablate it.
Okay, thank you, sir.
Yeah.
In thyrotoxic goiter, any experience, maybe you may or may not, other people, thyrotoxic goiter. See, patients are not being stable with the anti-thyroid drugs. Radioactive iodine, yes, is maybe if the good uptake is there, there's another option. So anybody who has done with this tumor ablation or thyrotoxic goiter, any experience in the literature, or if somebody else has done, if you have idea. Toxic nodule or toxic goiter, whatever.
Sir, there is data for autonomous functioning thyroid nodule ablation, and the patient will become euthyroid after ablation, and there is data for up to 2 to 3 years patient remains euthyroid. But sir, current recommendation is to go for RAI or surgery in a toxic nodule or toxic goiter or Graves disease. If the patient is not candidate for RAI or surgery, then current literature is indicating ablation or minimally invasive therapies.
Question is radioactive ablation. Problem is most of the people go for hypothyroidism later on. See, here you have got some control. So what is the difference? That is what I am asking.
Sir, we have had similar discussion with endocrinologist on this topic. So we have told that after embolization or ablation, the patient will be converted to a euthyroid status. So what they are telling is they would prefer a hypothyroid status so that patient is not having a second attack of Graves or thyrotoxic storm, so that patient will have symptom control. And if patient is euthyroid, then there may be a relapse of a toxic storm. That is what they are saying. But definitely if patient is euthyroid long term, then the cost of thyroid supplementation will be less.
Usually endocrine people say that the thyrotoxic is more dangerous than the hypothyroid. So if become hypothyroid, that is more safer to the patient than the thyrotoxicosis.
What about the specificity and sensitivity of the FNAC?
Yeah. And see, I'll tell you one thing. That human error is something, I mean, how do you predict that?
Yeah, the another option is that, sir, thyroid scan is required or not required? Because in hot nodule, cold nodule.
No, but in a sense, you do a baseline thyroid function test also. No? That gives you an idea if the patient thyroid, like hyperthyroid or not. So thyroid scan is not required.
Thyroid scan is not
No,
required.
No, not required.
And so like we have to take a consent for that. We are doing on base of the FNSA report. Anything can be happen in a future. Sometimes what happen, we are doing a practice and some practitioners say that they are doing not good. The report is fact.
So then you take the consent. What else do you do? They take the consent that your FNA is showing. But see, one common question which patient asks that, "Ye mera gaat hai." When I ablate it, does it mean that in the future I will never get cancer? See, for common patients, when you say the word gaat or tumor or whatever, they are automatically going towards cancer. They don't have the concept of benign as such. Now you tell them that right now it's a benign, non-cancerous thing. So then they ask, first of all, if I don't treat it, can it become cancerous? That's the first question usually I'm sure all of us get asked. Second, they ask that once I ablate it, does that assure that I will never get cancer? No, right? So we tell them that right now it is benign. After ablating, maybe your chances of getting cancer versus if you don't ablate is reduced. But if you're expecting that 100% will be cancer free, that's not. You can. But usually thyroid true gut biopsy don't recommend because you breach the capsule, so it's not advisable. Definitely. You can do. But like I said, 2 FNA, it gives you a good enough proof from 2 different sources if you want. Okay. And see, that human error, that is we can't do anything about. No, that I said, bilateral can't do. One at a time.
Device other than thyroid? It is used for liver, lung, renal, bone. Varicose vein. But there are other probes. Huh?
Can do. Parathyroid you can do. Breast fibroadenomas, uterine fibroids, liver HCCs, lung, all that you can do. But gangliomas, I don't know. Sorry, which lesion?
Cystic hygroma.
Cystic.
Applied in cystic hygroma.
It can be tried. I've never tried that.
And what about the?
So basic principle is what? What is your microwave? It's like you're like a cautery, you're burning something. So if you feel that area is safe to be burned,
hygroma is large. Sir, brachial plexus and the location of cystic hygroma is such that it will be difficult to ablate. Also the proximity to skin. If the skin is ablated, then it will definitely burn scar. Schwannoma, sir, in that also the proximity to nerves, brachial plexus, vagus, so it will be difficult. And there is no data also for this, honestly. No, sir, we can burn the tissue, but it should be safe, that is the thing. If it is within the organ, then it will be safe.
There are reports, case reports of head and neck hemangiomas being treated with ablation, but there are no guidelines. Laser? CO2 laser. RF. A normal tongue can get burnt.
So now we will end this session and we will go for lunch. Thank you all.